All right, and we are ready to go. This is three plastic surgeons and a microphone with, as always, the gentleman, Dr. Sam Jejurikar out of Dallas, Texas. Instagram handle Sam Jejurikar. Dr. Salvatore Pacella out of San Diego, La Jolla, California. His IG handle is San Diego Plastic Surgeon. And I am Dr. Sam Rhee from Paramus, New Jersey, and my Instagram handle is Bergen Cosmetics. So welcome, gentlemen. How are you?
Doing great. How about you, gentlemen?
Fantastic. Thank you. Good morning, everybody.
All right. Just remember, this show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based on circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified healthcare provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show. So this is going to be our breast augmentation show today. And I have a case from a wonderful patient who was very gracious to allow me to show her photographs and her results today. And let's get started. So this is mainly a way that I thought, I could hear both Sam and Sal talk about their approach in terms of breast augmentation, their thoughts when they interact with their patients, and what they think is important for breast augmentation. Obviously, breast augmentation is one of the most popular procedures. It's actually the most popular cosmetic surgical procedure in the U.S. for the past 10 years, with 313,000 patients alone in 2018, which is up 50% from 2000. And so, as a result, obviously, all plastic surgeons who do cosmetic surgery have, generally speaking, have a fair amount of experience with breast augmentation. So, this was a patient of mine who she's relatively young, um, no children, and she just wished to have larger breasts. What are the main things that you guys think of when you have new patient consultations for breast augmentation?
I'll start. And I'm sure I'm going to touch on a lot of things that Sal and you would say. So I think plastic surgeons and patients approach breast augmentation slightly differently. Patients oftentimes will come in and they sort of focus on cup sizes. I'm this cup and I want to be a 2 or 3 cup sizes bigger. I want to be a D cup, for instance. But I think we all, when we look at a patient like this, think about terms of a dimensional analysis. So when I see this patient, if you look at her, there's certain anatomic things you see. She's got some deficiency of breast tissue along the upper portion of her breast. She's got a well-defined crease at the bottom of the breast. In general, she is just lacking volume diffusely, but predominantly along the inner and the upper portion of the breast. So I'd want to find out, she wants to be larger. What does that mean? In Texas, that might mean something different than it might in San Diego, and it might mean something different than it does in New York City. But things that we'll do is we will, do some basic measurements. Every time you see a plastic surgeon, you'll see them pull out a tape measure and they'll measure things to look for degrees of droopiness. This patient doesn't seem to have much in the way of droopiness, what we call ptosis. We'll do things to measure the width of the breast. That'll help us determine what size implant we can put in the patient. We'll have a conversation about putting the implant in front of the muscle or behind the muscle. Generally, for most of us, the default position is to put it behind the muscle because it can do a better job of camouflaging the upper portion of the implant. It can do a better job of helping you preventing capsular contracture. It can do a better job with allowing you to get better mammograms in the future. And then once I sort of have that basic information, I want to find out a little bit more about her aesthetic goals. If she is leaning towards a very natural, relatively subtle enhancement, it'll steer me towards one type of implant, which I won't say everything. I'll leave some stuff for Dr. Pacella to talk about. If she wants a rounder, bigger look, we might try a different style. So those are the initial thoughts that go through my head when I see a patient.
Yeah, and those are excellent comments and excellent evaluation. Just to expand on that, I oftentimes spend a bit of time at the initial consultation talking about breast implants after the fact, kind of what to expect afterwards, particularly throughout a patient's lifetime. And a couple topics commonly come up. Number one is, I don't necessarily want to be in a position where I want to change these things out every 10 years. Patients often have this sort of misconception that it's, at 10 years, you got to change them out like a battery or a set of tires. And that's a common myth that I think was propagated by a lot of the implant companies and a lot of plastic surgeons wanting to get patients to come back for more augmentations at 10 and 20 years. And, in today's day and age, with all four implant companies that are involved in the United States or that sell products in the United States, we're seeing a much hardier construct of implants, exceptionally low rupture rate, in some instances less than 5% of the implant's lifetime. And so that's really important, I think, for patients to understand, is just because you have an implant doesn't necessarily mean that at 10 years you have to change it out. Now, I do counsel patients and tell them that the longer these implants are in, there's a significantly higher chance that there will be some issue with them. So if you're a young patient at age 22 getting a breast implant, chances are at one or two times in your lifetime, there's going to be a need to do a replacement or some sort of revision. And I think what many patients tell me as well, when I'm 65, I'm 22 now. When I'm 65, I'm not going to care what my breasts look like. So I'll just take them out and it won't be that big of an issue. But believe me, and I'm sure you two will reiterate this, is at 65, you're going to care.
Exactly. Yeah.
So,
more strongly. Totally agree.
Right. So the lesson here is that implants are a lifetime thing. There's no going back to just simply taking them out at 20 or 30 years down the track. The reason being is twofold. The act of putting in an implant will stretch out the tissue. It creates an anatomic space in the body that can't necessarily be filled up back with your normal tissue. The second issue is that tissue around the breast will stretch over time. So just like a normal breast would age. And that's oftentimes very difficult, if not impossible, to correct without placing another implant later in the future.
I think it's for me, these initial patient consultations can be challenging because there's so much information that has to be relayed to a patient. And Sam touched on many aspects of it, and so did Sal. And so it's sometimes not so easy for a patient to process everything, especially when their only goal is, I want my breasts to be larger. And to know all of the things that you two have mentioned, it does take a little bit of time to process that. I think one of the things that was a takeaway, I don't remember who said that at Michigan, but it was always, these are, these are not implants that you're going to have for the rest of your life. At some point, you're going to need another operation, probably. If you're, even if you're young or old, you may need an upsize, downsize, exchange, deal with scar tissue, what have you, leak. So I always tell patients, don't expect that if you have implants put in that you will never have to worry about them again. There is care involved, just like there is anything that's man-made. I am interested in hearing, I know, Sam, how you two determine what volume is appropriate for a patient. Like you said, there are major regional variations, and there's also a way of trying to find out what the patient wants. And I know, Sam, you do digital imaging, and I'm interested in hearing about that, as well as what else you guys do for that.
Yeah, I'm a big proponent of 3D imaging. I use Chrysalix software in my practice. I don't think it's foolproof by any stretch of the imagination, but it's an excellent communication tool with patients. So what I would typically do for a patient that I'm seeing for a consult like this, and this is happening via telemedicine these days, this is happening even in person in the office, we'll do some basic measurements and I'll try to get an idea of what aesthetic she's looking for. Does she want to look natural? Everybody says they want to look natural when they come in. Not everybody really means that. How big of an enhancement does she want? How much roundness does she want on the top of the breast? And then based off of the diameter of the patient's breast, I will make some initial implant selections, and we'll adjust the implant profile. So a lot of patients will come in with pictures of patients that they like, and they'll see different names like moderate profile, high profile, moderate plus, full profile, and they don't really quite understand what it is. What profile basically is a way to look at the relative width to the projection of an implant, meaning a high profile implant is a relatively narrow, rounder implant that's going to give you, in general, a faker look, more roundness on the top, which some patients really want. The lower sounding the adjective is, so moderate sounds lower than high, the less the implant will stick out, the more natural slope you'll have on the top of the breast. So if this patient were to tell me, I want to have a natural appearing breast, and she genuinely wants that, and she wants to be, 1.5 cup sizes bigger, I might start showing her some implants that are moderate profile implants with 3D imaging to get a sense as to what she's looking at. If we agree on one that she actually likes, I'll make sure on the day of surgery, I'll actually have that implant plus some others there as well, just in case the measurements that we came up with 3D imaging aren't accurate, which oftentimes they are not, particularly when the patients are doing their own measurements at home. But that's how my basic approach would be. It's a lot of back and forth, a lot of communication, a lot of additional communication, even after the initial consultation when there's some buyer's remorse about the size they chose.
Right. I think, a phrase I really believe when it comes to sizing for breast augmentation is a picture is worth 1,000 words. And, if you guys use the 3D imaging software, unfortunately, we don't use that in our practice. And I haven't found it as predictive as just simply asking patients to bring in some examples of photographs. And when I meet them again for the second time for the preoperative examination, I ask them to bring in photographs from, not necessarily from breast augmentations before and after that they may find on the internet. Those are helpful, but pictures of patients or women, just in popular media. So, for example, in a swimsuit magazine or a swimsuit ad, and what that's really important for me to understand is the upper profile of the breast. All of these breasts look different in a bra versus without a bra, and patients, I think, sometimes can't necessarily articulate that, and so when I have that situation very frequently is when a patient comes in and says, I want a natural look, and then I ask them to bring in photographs, and they have a huge projection implant that basically they can put their White Claw on top of it. Okay, that's a very high profile implant that is not necessarily going to give you a moderate slope or a natural look. So bringing those pictures to the preoperative appointment is critical for me, and the patient sizing. And I bring those in the operating room. I hang them up in the operating room. I try to match it one for one as much as I can. I think in general, when it comes to ordering the size of the implant, I try to get patients to be a little bit flexible on the size. Many times patients will come in and say, well, I saw this online. This woman has a 325 moderate plus. I absolutely want that implant. Well, that may not really be a great size implant for you. Every patient is different. Every size of breast, both the projection and the width, are different. And so I usually try to get a range of implants within about 50 cc's or so. So that way we have the ability to go up or down based on the particular size. And going back to Sam's Jersey Sam's patient here, when I look at this patient here, the left breast looks just a smidge smaller than the right breast to me. And that's something that is going to, when you put the implant sizer in the operating room, that's something you're going to necessarily notice. So I want the flexibility to add 25 or 50 cc's onto that left side if I wanted to, and that's oftentimes not that easy without having a variance of sizes.
Listening to both of you guys, two things strike me. One is there's a variety of ways to understand what the patient wants. And it's like surgery. We have all sorts of different tools. it doesn't necessarily matter what that tool is, and we're all good with our tools. So whatever we like, we use, whether it be Crystalix and digital imaging, whether it be assessing what the patients bring in photograph wise. I also use sizers, which are these, basically silicone shell type cups that patients can test with as well. I feel like all of these things are very good, and the key that the other takeaway I'm getting is that it's trying to really understand what the patient wants. And one of the big things is that upper pole fullness, like how big is that breast going to look on the upper part of it, and whether it's White Claw, big or natural appearing. That's a good one. I'm gonna have to use that. That is I think we all realize that is a big aesthetic that we have to understand what it is that the patient wants, because sometimes the patient does not even realize that until they see their own imaging, or bring in photographs of themselves, or try different things. Um, what is it that you guys, when patients ask, what are the major risks or concerns? What do you touch on with your patients before breast implant surgery?
I mean, the one that I think we probably all spend the most amount of time talking about is something called capsular contracture. That's the most common complication that you'll see with a breast implant, and the incidence of it varies depending on implant and anatomic location. But it's thought to represent a low-grade bacterial infection, or a biofilm, basically around an implant. So we talk about tools that I can do during surgery to try to limit the incidence of that happening. We all use a variety of antibiotic concoctions during surgery and iodine ointments to try to diminish, bacteria from the skin from actually getting into the pocket. I'm a big fan of something called the Keller funnel, which I'm not sure if you guys use it or not, to insert the implant. It allows a no-touch implant. There's still a lot of surgeons that don't use it, so that's why I don't. It introduces a small cost, but yeah, I'm shocked by the number of plastic surgeons I know that still don't use it. But it allows you to do a no-touch technique to put it in. So we'll talk about that. The two complications that people really want to spend a lot of time talking about, and I'm going to bring them up and then let to hear Dr. Pacella and your take on this, are breast implant illness and breast implant associated lymphoma. So I'm curious what you guys tell patients about those two risks.
Yeah. So to back up a little bit here, I really talk about complications in two scenarios. There's the immediate complications from the surgery, and then long-term complications afterwards. And so, and we touch on these very briefly. We give patients a big, large packet or documentation talking about every specific potential complication in general. So we basically just graze on this in our pre-op appointment. So immediate complications based on their health. Anesthesia is very safe. Obviously, it's a short procedure. We're not involved in big major body cavities where there's potential for damaging major deeper structures. But the most common complication immediately after surgery is the risk of bleeding, and I give patients a percentage. This is less than 1.5%. If bleeding does occur, and it's a small amount of bleeding, we can oftentimes manage it, so we just compression and ice. But if it's a substantial amount of bleeding, meaning a hematoma and blood is collecting in the pocket, we have to take you back to the operating room, and sort of we talk about the ramifications of that. And then going on to the long-term complications, you touched on the risk of capsular contracture. We do go over that. But as far as the two topics of breast implant illness and breast implant associated lymphoma, I do give patients some literature on that. So let me first talk about the lymphoma risk. I really want to highlight that risk of developing breast implant associated lymphoma is almost exclusively in implants that are textured versus implants that are smooth. And like most surgeons across the country, I've tried to just completely remove textured implants from my practice in order to mitigate that risk. The other thing I talk about is there's some data on the specifics or different types of companies based on their their type of texturing. And there is really one company that has been implicated with the highest risk. That's the company that has been removed. Their texture device has been voluntarily removed from the market. And I don't actually use that particular company. I use the other two companies. So in general, that's a very low risk that I think patients are willing to accept. The concept of breast implant associated illness is a little bit nebulous. Unfortunately, we don't have a ton of data out there, and arguably, silicone breast implants are probably the device that has been studied the most out of the FDA for the last 30 years. I mean, we have a tremendous amount of data on this topic, but no data set has really implicated or created this idea that breast implants cause systemic illness. And I don't necessarily say that that's not real. I think there is some component to it. But I can also say that many times in my practice, when patients have come in and they've said my breast implants are causing X, Y, Z, we've went ahead and taken those implants out, and none of those patients have actually improved their symptoms, which tells me that there's probably some other, inciting cause to autoimmune disease or rheumatologic disease, et cetera. So it's a very vague thing. I think we don't necessarily have a huge handle on as surgeons.
So when you say those patients didn't get better, you're doing implant removal, on-block capsulectomy.
Correct. And no replacement.
And what period of time did you follow them?
Usually I follow patients at least 2 to 3 years afterwards, usually every year, just to check on them. So, most of these patients have been 2-3 years out,
Very interesting.
What has been your experience?
I've seen a lot of women that have come to me with implant related problems that they have called breast implant illness. And I think probably 85 to 90% of the time, it was profound capsular contracture or malposition issues, or just related to the size of the implant. So, those are legitimate, real implant-based problems that require surgery. There's been about a half a dozen who genuinely had sort of autoimmune type of symptoms: food allergies, hair loss, generalized fatigue, arthritic type of symptoms, who we've taken out their implants, done en-bloc capsulectomies, and initially not a huge improvement, but over the course of 6 to 12 months, an improvement. And I've actually seen in the women that I was pretty convinced had breast implant illness, I've seen an improvement in all of them. Not complete resolution of symptoms, but improvement. Mm-hmm. So, but a lot of, there's been a lot of cases where we've done en-bloc capsulectomies and we've done implant removal, but I really think it was more for capsular, grade 4, which is the most severe type of capsular contracture. And then doing that's a great treatment for that too.
Jersey Sam, let me ask you this. When patients come in and ask you to perform an en-bloc capsulectomy, what's your discussion with them? What do you tell them?
I mean, I don't do en-bloc very often. I will, I think
but there's specifically a patient that says, and the reason I ask is there's a huge internet push on this topic, the en-bloc capsulectomy. The idea is that somehow there are some humors inside the implant capsule that if they are violated during the course of removal, that those are going to increase the patient's symptomatology. So a patient, what I'm curious about is patients that come in and ask specifically, do you do this? And am I going to have this done?
I have not done an en-bloc, I think, in a very long time. If someone comes in specifically asking for that, I don't think I can ever necessarily guarantee that I'm not going to release evil humors at the time that I do a capsulectomy like that. And my question really is I don't really have issues. I mean, the issue is this: breast implant illness is not well defined. It's a very difficult phenomenon to quantify because we don't have good data on it that is extensive in terms of real research. There's no doubt that we have seen anecdotal cases, but we've also had anecdotal cases for rheumatoid and lupus and other autoimmune diseases associated with breast implants for many years, and none of the studies have borne that out. Um, how many patients are you seeing that want on-block capsulectomies and that are demanding that as their only treatment to address their symptoms?
A lot. A
Really?
lot. And I will say that part of it is because I'm involved with a major health system. I take insurance, and that is this is usually a reconstructive phenomenon that we see. Texas Sam, let me. Can you answer that question when someone comes in?
Yeah. So that's a great question, because I'm also seeing a lot of patients that want this done, and I want to be able to do it on everybody that asks it, but it is a difficult thing to do in certain patients. If you have a patient with a severe capsular contracture and thin breast tissue and a thin upper pole tissue, it can be technically challenging to do that. And sometimes it is nearly impossible to get it out on block. So we'll have a discussion at that point about my desire to perform a complete on block capsulectomy and what the alternatives are if I can't get it out in one piece. I'll stress to them that I will take out all of their capsule, even if I can't do it on block. And for the people listening, on block means you're taking out the implant and the entire capsule, the front and the back wall of it, out in one piece. In a relatively large breasted with natural tissue woman with a smaller implant, for me, technically that's easier to do than in a woman who has a dense capsular contracture and a relative deficiency of breast tissue. So if, and like you guys have said, the data, there's not a lot of data to suggest that capsulectomy is, or to prove that capsulectomy is required to treat these vague autoimmune diseases. However, there's a lot of people that have very strong feelings on this issue. And so it's my desire to be completely truthful at all times, discuss because I have seen surgeons who are basically crucified on the internet because patients will accuse them of not having taken out the entire capsule afterwards. This is a huge bone of contention. So if someone says, I need you to take out the whole capsule, or we have this discussion, I'll take it all out, but I'll be honest about my ability to do it in one piece versus not do it in one piece.
Right. And there are unfortunately, this sort of goes back to marketing and media in plastic surgery. And unfortunately, there have been some surgeons in this country who have really taken advantage of patients, I think, and created this idea that you can only have a en bloc capsulectomy, and to me, it's like a yeti, a unicorn, or a mermaid. Those all sound really cool and feasible to exist in the world, but in practice, they probably don't exist. The surgeons that say that I only exclusively do en bloc capsulectomy, I don't think are being as truthful as the rest of the country. This is particularly the case with implants that have been placed submuscular. It's exceptionally difficult at times to take off the back of the capsule on the chest wall. You're talking about right on top of the rib cage. There's lung tissue that's right below this. And scraping off every little piece of capsule can be near impossible, if not impossible, to do it all in one swoop. So I think, the key concepts I think for patients to understand is ideally we do want to do an en bloc capsulectomy if possible, but oftentimes it's not possible. And the consequence of doing that is you could take an operation that requires a scar this big to one that requires a scar this big. Mm-hmm. And that's sometimes a very difficult pill for patients to swallow.
I completely agree with that assessment. Yeah, completely.
So so let's move on to the results here. I think we're running close to the end of our block here.
All right. So the patient opted for, and we didn't get to it, but saline implants. They were high profile, and they were done as we commonly do, is submuscular or partial submuscular, so dual plane. and through an inframammary incision, because you can't see the nipple, so I'd have to tell you that. So it was an incision right at the base of the chest. And Sal was right. I did 380 on the left and 350 on the right. So you called it in terms of the asymmetry. And
did you do a tummy tuck too? Some lipo?
It was funny because you told me, remember we talked about this in one of the podcasts, how we don't have, like, I was like, patients that come back for multiple procedures.
Yeah.
And you said more of your patients do that than you think. And she did. This was after she actually had her breast aug, and then she had a lipo BBL done about a year or two after. And so this was actually after the lipo BBL as well. So this was actually like a 2-year post-op result for the OWN.
Great.
Very nice.
It's a great result, Sam. I really think you really did a couple things exceptionally well here. Number one is just the natural appearance of the implant. And this is, our viewers and listeners may not necessarily appreciate this, but to get this type of result with a saline implant at 2 years is exceptional. And, it really has created a lot of good lower pole fullness and good natural slope to the upper pole. This just looks great. No rippling whatsoever that I could see from this, which is sometimes a risk with saline implants. So you really hit the nail on the head here. The other thing I think that you did exceptionally well is the cleavage area, particularly at the lower pole on the inner surface of each breast. If you look at the right breast on the preoperative photograph, you can see that, maybe it's just the shadow, but many times the breast has a little bit of a cone-like appearance to it. And that you can see that clearly on this gal on both sides, but more particularly on the right side. So she doesn't really have a ton of extra breast tissue on the middle of the breast down at the lower portion right here. And you just masterfully filled that in with your implant, which looks phenomenal. So really, really great job.
Thank you. I appreciate that.
Kudos. Wonderful result. Really, I echo everything Sal said.
That was great. I appreciate all the kind words on that one. I know you guys have, I think it's interesting to see how many regional variations there are in terms of what are the most average size implants that you typically place in your practice?
I mean, there's a huge range at this point. It ranges in my practice from 200 cc's to 800 cc's. It's all over the place.
Okay.
It's not the same stereotype of Texas that always has previously existed. Everything is not always bigger in Texas, but sometimes it is.
Yeah. I would say that, in general, the average on the bell curve is probably in the range of 350 to 450 that I would perform. Yeah.
That sounds similar to me too.
And, just to back up here for our viewers on that last result, all three of us have trained together. We're all very, very close friends. And we all, I think, have an artful and masterful way of telling each other that we're full of doggy doo-doo. So we're not three people that would shy away from telling each other, "Hey, that's a terrible result," or you're just completely off base here. We all three of us have comfort in telling each other that. So for us to really say that, the results look fantastic. I mean, this isn't honest. We're not just trying to pat each other's back. Oh, you're awesome. No, you're awesome.
Yeah.
So it's these types of results, I think, are very difficult to achieve, and I'm honored to be in the broadcast studio with these two jokers.
Well said, Dr. Pacella, as always.
And with that, thank you so much, Sal. Thank you, Sam. Hope you have a great Sunday. Enjoy.
Take care, gentlemen.
Take care.